I'm here today with Dr. Banful from Medifem Multi-Specialist Hospital and Fertility Center. And for me, this is especially great because he is my personal doctor. And we are here actually to talk about the documentary 1,000 Needles, which looks at the experiences of women who live with conditions like endometriosis, adenomyosis, uterine fibroids, and the impact on their lives mentally, emotionally, physically. Welcome, Dr. Banful. Thank you for being here. First, I want to ask you, how prevalent is it for women in Ghana to have some sexual and reproductive health issues?
Well, Nikitta, when you say sexual and reproductive health issues, it's very broad. Maybe we should limit this to our endometriosis and the horrors and the nice parts of the endometriosis. It's quite prevalent, actually. I won't be able to give you figures, but it's quite prevalent, and any gynecologist in fertility management who looks out for endometriosis will find endometriosis. 40 years ago, 50 years ago, it used to be said that it didn't occur in the black woman. But because nobody was looking. With the advent of gynecological laparoscopy, endoscopy, we're able to pick up the endometriotic lesions and marry them with the symptoms that the woman is having. Right. And you know, it can present in a variety of ways. We'll tell you some more if you want it.
Well, I like that you mentioned endometriosis because on social media, people claim that the month of March is National Endometriosis Month. What exactly is endometriosis for people who don't know what it is?
Medically speaking, you see, in every woman's womb, you've got the muscle, you've got the lining. And every month you shed the lining. For some strange reason which we don't understand, some of the lining finds itself outside the womb. So, when they are there, you have this monthly cycles when you should be shedding the lining as a menstrual flow. Some of it gets shed into the peritoneal cavity, so to speak, the pelvis. And that is where the problem is. Some of it also burrows itself into the muscle of the womb. Remember I said the womb is muscle and lining. When it goes into the muscle of the womb, we then call it adenomyosis. And it behaves exactly the same way. You are having a menses at the end of the month. You bleed normally, and you bleed into the muscle of the womb. And that's where the pain is. Endometriosis, if you ask me, Dr. Banful, please spell endometriosis, I'll say P-A-I-N.
I like that you mentioned pain. My biggest issue is pain because I have pain quite often. But if we were to talk about some of the other symptoms that occur with women who have endometriosis or adenomyosis, like you mentioned, what are some of the other symptoms?
Well, pain is a very big part. Difficulty in having babies, pregnancies. And it can also occur very rarely in strange places. I personally have managed a patient who would every month during her menses cough out blood. The physicians didn't know what was happening. It took the cardiothoracic doctors who did endoscopy, looked in, saw this funny tissue there during her time of her menses, took a biopsy, sent it to the lab, report came back, endometriosis. But the one which intrigued me most, personally, was this lady, and this was when I was working in South Africa at the time. She came to me and says, "Doctor, every month I go blind in my right eye." What's going on? Okay, when do you go blind in your right eye? At the time of my menses. So, could it be endometriosis? The eye, womb, so far away. Like, no, Alaska and Antarctica. So far away. Okay. come and see me when you're in your menses, but I looked at the eyes, the eye grounds. Well, I didn't see much. Her menses started, second day she comes in and she can only use the left eye. I look in there and the eye grounds that were clear, now very blurred with blood. You can see blood there. So I called my friendly ophthalmologist and said, hey, I've got some interesting thing for you. The patient went to see him, and the tall and short of it is that he confirmed endometriosis. Lasered it, it's fine in the eye, but she still had the problem in the pelvis. So yes.
Can endometriosis be cured?
Difficult question. Endometriosis may be curable, depending on where it is. If we have access to it and remove it, yes. But you see, we don't even know what caused it in the first place. It's a disease of theories. There are about 10 theories about it. I wouldn't go into that, but Samson's theory, which you may have read on the line, is what some of us accept as the likely cause of it. We manage it either medically or surgically. If we know where it is and we can cut it out, we may say, may be cured. But it has such a high recurrence rate. That's the disappointing part. Such a high recurrence rate that in most books, between 35-40% sometimes, depending upon which method you use in treating. It is a difficult problem. Endometriosis will drive you, the gynecologist, up the wall, drive the patient up the wall, drive her relations up the wall, and in fact, drive the sisters who manage her in the hospital also up the wall.
Is the recurrent rate the same with fibroids?
No, fibroids has a much lower recurrence rate. Much lower recurrence rate.
You mentioned about children, and I wonder, what is the biggest reason why women seek out a gynecologist? Would it be in order to preserve their fertility? Would it be for the pain? What is the number one reason?
I hope I don't get shut down by the gender activists. Women are interesting species. A good many of them may come to you for fertility reasons. And then in your history taking, you pick up that actually the main problem they have is this monthly menace, monthly hell. Then they may own up to it. And if you chase it up, you may be lucky.
But do you think that a lot of women think that the pain, because they don't know they have endometriosis, they think maybe it's just bad period pain, or they think it's normal?
Many women think that they are designed to have pain. And I keep saying that God didn't do that. You are not designed to have pain. They think that once you start your menses, you must have pain. And the pain of endometriosis is different from the pain that young women have when they start their menses. The young women have the sort of pain they have. They see the blood, and then the womb goes into contractions, and they have the pain. Endometriosis is the reverse. They have the pain a few hours, a few days before, and then it rises to, then they start having their periods, then it rises to a crescendo, because if it is in the muscle, it fills up the muscle, and as it fills it up, it is painful until it starts coming out.
Is this the same with adenomyosis?
Precisely.
What about fibroids?
Fibroids don't cause pain unless they are undergoing what we call degeneration, one of the 7 types of degeneration.
Does it compromise fertility severely? Any of these three?
I'd rather have fibroids than endometriosis as regards fertility.
Okay.
Yes, fertility is affected. We're able to manage that associated with fibroids a lot more easily than with that of endometriosis. And for some strange reason, in some women with endometriosis, even the quality of their eggs are affected.
Okay.
So that if you have to even do IVF, assisted conception for them, their results are a little lower than in the non-endometriotic patient. We don't know why.
I've heard from different places that having children cures fibroids or cures endometriosis or adenomyosis. Is this true?
Having children does not cure fibroids. Having children quietens endometriosis.
Quietens.
Endometriosis our aim of management are two. We either create a pseudo-pregnancy or create a pseudo-menopause. Once you are pregnant, we remove the cyclicity. Endometriosis, the problem is the cyclicity. So it's quiet during that time. And if you are pregnant during that time, it's quiet. Right. As opposed to fibroids. Indeed, as we speak here now, there's one patient of mine who's in her third pregnancy, no name we mentioned, but before we saw her, she had been given up by her doctors in America. She had tremendous endometriosis, but thank God, she's a very happy mother of 2 now.
When women leave the hospital and they go home, what is the effect of having endometriosis or uterine fibroids on them? So on their lives, but also on the lives of the other people around them.
In my book, endometriosis is not a disease of the woman alone. That's single patient. It is a disease of the family and of the society the patient is in. Remember I said it will drive you up the wall, drive the nurses, the doctors, the family. Now, if you're a man married to a young, beautiful woman who every month she is in pain, you start wondering whether you are the source of the pain. She can't go to work. Her employers think she's a malingerer. She's a shaker, doesn't want to come to work. She comes to hospital, the public sector, so to speak. She said, hey, you're always here. You can become a pelvic cripple, as we call it. And some women have contemplated suicide because of endometriosis. So it's not a disease of the patient alone. And that's why when we see patients with endometriosis, we try as much as possible to get her close people around her to explain to them, because family support gives significant success.
The first time I came to this hospital, I remember sitting downstairs in the O.P.D, and all these women who were there were way older than me, and they had children, and I was 19 at that time, and I felt so out of place. I felt completely out of place. I wondered what they were thinking about me. Were they thinking, what's this girl doing here without her family? What is the age range of the women who come to see you?
We usually see the endometriosis patients in the reproductive age group, those who are wanting to have children. But I must say, Nikitta, you were one of the youngest I've ever managed. And that was my worry. And when we saw what was there, there was a dilemma. But God is good.
Yes.
So you are now smiling at me.
Yes, I am. What happens to women who have endometriosis or fibroids? How should they manage their lifestyles in a way that can mitigate the pain, mitigate the challenges and the problems with living with it?
First of all, education is a lot. They need to be interested and read up about the problem and ask their doctors, the interested doctors, to explain things to them. It's half the battle won if my patient knows about endometriosis. So often I write the name for you, endometriosis, please go and Google it. And next time we can have an oral exam. Kind of. Because once they get to know it, my problems get solved very easily. Because it can be a dilemma managing the patients. And remember, there is chronicity. So you don't see her today and that's it. It's not like malaria you treat today and gone, diarrhea today and gone. It's almost a lifetime. That's why our patients become our friends and you have become my daughter. It can be very challenging. So we take pride and joy when we see that this patient who came in very miserable is now a happy woman. More so if there are little children to show for that.
I think I can add to that because I did a lot of doctor shopping before I settled here, and as you mentioned, I was very young, and my biggest problem then was the way doctors reacted to me. And I remember one doctor looking at the ultrasound, and then he laughed, and then he said, "Are you sure you are 17? This is strange." And then he made another joke, but it was very offensive, and I remember thinking, I don't want to stay here with this doctor. And we moved on, and there were some, who pushed for surgery. Immediately you get to the office, it's like, we have to do this, without really explaining to you what is going on, which terrifies you even more, the idea that I need to have surgery, because you start to wonder, do I need to have surgery again and again and again? And it's very difficult. So thank you very much, Dr. Banful. It's been a very educative conversation with you. And for me personally, thank you for being there for me when I was completely miserable and helping me find my feet again. I think that having certain conditions, the kind of doctor you have is very important to your journey, because like you said, it is a journey. It's not malaria, it's not typhoid. It doesn't go away with taking a pill. It's something that changes your whole lifestyle, and the kind of doctor you have, the kind of nurses you have around you really help in your journey. So thank you very much.
To wrap up, I think I'd like to make a plea to my healthcare colleagues. It is not every woman who comes to you with period pains who has pelvic inflammatory disease. The differential diagnosis for endometriosis is PID, as we all know. So we all start with PID first. But if we are able to take a good history, examine the patient, use adjunct investigations, good ultrasound, good pelvic ultrasound, laparoscopy, if you have it, is a gold standard. But more importantly, let's maintain a professional but empathic doctor-patient relationship. That will convert miserable young patients because of pain into lovely, happy patients. And that will also make us doctors happy, be declared heroes, or we are not.